We're going to start. So we're starting with chapter 6, which will be talking about chest and thoracic cavity. If you read or skimmed over the chapter, there's a lot of information. That's your chair right there. I started a little bit. Okay. Thank you. That's okay. So if you skimmed over it, read the chapter, you saw that there's a lot of information, there's a lot of images, both CT and MRI of the chest. We don't cover all of them necessarily. I want you to pay attention to what I cover on my PowerPoint specifically. And then if you have questions, we can go over them specifically. Okay? Let's do a little bit of basic anatomy from last year, right? From radiographic anatomy and positioning. So this is the bony thorax. And what does bony thorax do? Right. I'm going to just write. So the main job of the bony thorax is to protect the lungs, protect the structures that are in the thoracic cavity. If you look at the bony thorax, anteriorly you have all the ribs, right? All the ribs are protecting it anteriorly. In the back you have the thoracic vertebrae, right? Posteriorly. Let's keep it like this. This doesn't. Let's see. Come on. Yeah. So I'll keep it like this. In the back, you have the thoracic vertebrae that is protecting. And also, anteriorly, you have the sternum, right? The superior portion of the sternum is manubrium. This is all repeat for you guys. Here's the body, and then inferiorly, you have the xiphoid process. And all of these produce like a cage kind of a structure, which we'll call bony thorax, to protect all the structures inside. There's also thoracic inlet and outlet that you're looking at, hopefully soon, right? Thoracic inlet, that's superiorly, that is the opening for what? What do you have the opening on the top of the bony thorax? All the vessels, the nerves, right? The important vessels to go in and out. And also you have a thoracic outlet that is at the bottom. That is basically where the diaphragm is, and again, it could be an outlet for some structures coming out. Okay? So speaking of the sternum, how many of you have done an x-ray of the sternum? Wow. Yeah, you're right. We know you have done it. Right. So not too many of you, right? We don't do, unfortunately, or maybe fortunately, we don't do sternum x-rays as much, but it won't, the lateral sternum x-rays that we used to do, they won't come out as good as this one. This is a CT reconstruction of sternum that they did, and they were probably looking for some kind of fracture. Why would you do a sternum x-ray or CT? What would happen to get it fractured, for example? Trauma, right? Motor vehicle accident. If you hit the windshield, the driver, the steering wheel. If you hit any of those while you're driving or there's an accident, obviously sternum fracture happens. So now we do CT. We don't wait for x-rays anymore. And actually, if you did a sternum x-ray, how did you do your, Jose, how did you do your PA? Mm-hmm. Did it come out okay?
I shot it a second. We did it again with lower techniques.
Lower technique, breathing technique or lower technique?
The breathing technique, and then also do the decrease of baby.
How many seconds? Do you remember? Yeah, could we?
Lower our mass. I mean, our MA.
Right. So you lower your MA, you increase your timing so that you can actually do a breathing technique. You don't tell them to hold their breath, you do a breathing technique, and then you're supposed to get the sternum on the shadow of the heart. Right. Remove, exactly. And did it come out okay? Very good. So if you ever do a sternum x-ray, it's not very easy. And I remember as a student, the techs used to do them, and they would show it to us and says, okay, where is the sternum? You kind of have to imagine it, where the sternum is, and kind of look at it.
You know, like, well, the first time we're like, well, how are we gonna, how we collimate?
Collimate.
But then we kind of just do, put based on the situation.
Where was that? I wonder where'd you do
VA is full.
VA. Okay, very good. We don't do them as often. So if you say, grab it and try it, because it's really worth trying it, and it looks really good on the x-ray. Okay, so the same thoracic inlet and outlet, we can look at it on a CT actually. So for those of you who did CT in the summer, or you're doing it right now, this is one of the first slices you see on a CT chest, correct? So you're looking at the lungs, which look black, right? On the right side and the left side. And what else is black there? What's this over here? Esophagus or trachea? Trachea. It's trachea, actually, right. Esophagus is more posterior, and you don't always see the esophagus open like this, but you should always see trachea open, or patient's dead, right? If the trachea is not open, they can't breathe. So that's the trachea. Next one is an image of thoracic outlet. So way at the bottom, close to the to where all the ribs, everything is gone, close to the diaphragm. You can still see some of the lung. You'll see the liver there, some of the stomach on the left side. So that would be one of the last slides you'll see on a CT chest. Usually they want to see all the way through the liver. This would be one of the last slides. Okay, so let's talk about the lungs and the pleural cavity. This may be, again, maybe a repeat for you guys. You've heard of this before. So the lungs, each of the lungs, the right and left lung, are both in a cavity. That's called pleural cavity. The pleural cavity is not an empty cavity. It has some fluid in it. Why do we have fluid in the pleural cavity? Lubrication, decrease the friction, right? Because your lungs are always moving, you're always breathing. You don't want any friction between the lungs and the bone, right? So you always want to have this cushion-like structure between the lungs and the bones. Now, what's important about pleural cavity is that it has its own layers. It has its own membranes. There are two membranes that you need to know. One is the parietal pleura, which is this one right here, parietal pleura, which is the outermost layer of the pleural cavity. It's attaching to the bone. The other one is the visceral pleura, which is this one. And visceral pleura is the layer that attaches to the lungs. Important to know those. Important to know where the pleural cavities are. Both sides, both right and left. So what happens, now we said there's a small amount of fluid in the pleural cavity just to give the lungs the cushion and the ability to move. And it's also vacuum. That space is also vacuum so that it keeps the lungs expanded all the time. We can breathe better. What happens if the amount of fluid in the pleural cavity changes? Decreases or increases, or infection happens?
Changes the volume of your lung, like the capacity of your lungs.
Right, so you're not able to breathe as well. So you get patients, some of them may be older patients, come into ER, they have shortness of breath. They can't breathe well. Maybe there's pain in their chest, and you look at the CT, you look something like that. That's fluid, and it's called pleural effusion. So that area right there, that's not supposed to be there. That's all extra fluid in the pleural cavity. It's called pleural effusion. What do we do for these patients? Thoracentesis. You guys have done chest x-rays after thoracentesis a lot, and some of you might have seen thoracentesis done in ultrasound. So they actually go in ultrasound, they puncture posteriorly, they puncture their pleural cavity, they take all the fluid out, and the patient feels a lot better. Sometimes these patients come once every month because it's just the way their disease is going. Maybe they have COPD, maybe they have some kind of a heart disease that creates that fluid inside the pleural cavity. And in the hospital, we see those patients sometimes frequently coming in. Okay. Questions so far? So we're going to talk about the lungs now and see what happens in them and how they work. So what do the lungs do for us? What's the main function of the lungs? Oxygen, right, oxygen exchange, right? We breathe in O2, we breathe out CO2. All of that is done in the lungs. So it starts from the trachea, actually, right? So the trachea comes down and it divides into two, which we call them the bronchus, right? The left bronchus and the right main stem bronchus. Right at the division of the trachea, this area is called carina. Very important to know that area. So the area where the trachea bifurcates and goes into the two lungs, the right and left, is called carina. The opening to the lungs, because there has to be an opening, right? When the trachea divides, the bronchus, they have to go into an opening. The opening is called hilum. Okay, very important. So the ones that I'm underlying, obviously those are the terms and the structures that you need to know. Hilum is the opening, correct. Correct. So far we know the trachea divides, it gets into the lungs. What happens after that? What happens to all these branches? Huh? Bifurcates, right? So it says about 22 times these bronchus, they bifurcates into smaller and smaller, and we call them bronchioles, right? At the end, we call them bronchioles. And at the end of these bronchioles, you have very small units that has that actually the gas exchange happen in them, and they're called alveoli, right? So at the very end of the bronchioles, you have the unit of the gas exchange that happens in the lungs. It's called alveoli. Okay, very good. So this is a CT chest again. We're not going to look at the arteries yet because we're not there, but just this is basically looking at the left main stem bronchus and the right one and how it's dividing. And if you look, this is the left side and this is the right side. And it's showing where the hilum of the right lung is, where the bronchus is going in. We'll look at this a little bit more later. This one is another one. Is this one more inferior or superior than what we just looked? So now you're actually looking at the carina where you can see the bifurcation. So is this slide higher or lower than we just see? So it's more superior, so it's higher. You're actually looking at the bifurcation, which is right here. See how it shows carina right there? So you're looking at the bifurcation right there, and the left and the right and left bronchus are going into the lungs. Here's another one. It should be in the same area because, again, you can see the carina right there, and you can see the two branches of the trachea going into the lungs. Here's a fancy picture. This is another CT, 3D reconstruction of a coronal CT. CT chest they were doing. This is just to show you how they can change. The axial images of CT can be changed. You can make it a 3D. You can make it so many different planes. This one happens to be a coronal plane. It's amazing how they can do these things with CT now. Okay, so let's go into the mediastinum. So middle of the chest, mediastinum has certain structures that are really important. Vital structures, for example, heart, aorta, right? Trachea and esophagus that are back there. Also thymus gland. These are all structures of the mediastinum. And we're going to talk about each structure a little bit in detail. We'll go more into detail with the heart and the aorta and the other greater vessels. So let's talk about thymus gland. Thymus gland is this tiny gland right here that's usually behind manubrium of the sternum. Most of the time, for those of you who've done CT, have you ever seen thymus gland on an adult? You probably won't, because by the time we're adult, the thymus gland shrinks. It's only on children. So hopefully some of you, if you go to Children's Hospital and do CT, you may actually be able to see the thymus gland on those patients. What does thymus gland do? Anybody? So there's a hormone that thymus gland actually produces. It's called thymosin. That's the hormone that helps with the immunity of the body. What else does it do? Maintenance of the immune system, basically. That's what thymus gland. And again, in an adult, it's very, very small where you can't even detect it on a CT. Let's look at some of the CT images of actually CT of children that were done. So here's the thymus gland on a child, right there. So it's behind the sternum and it's anterior to the aorta. Look at another one. This is a CT image. Again, you can look at the thymus gland right there. Maybe one more. No, I don't have any more. So that's it. Let's talk about the trachea and esophagus. Those are also structures of the mediastinum, right? So we already said trachea is the structure that's more anterior, right? Esophagus is posterior, and it's between the vertebrae and trachea, always. That's how trachea and esophagus are. And that's how you can locate them. How else can you tell which one is trachea, which one is esophagus? On a cross-sectional image. Black, right. Trachea is always open, always full of air. It never collapses because of the cartilages, the C cartilages that are around the trachea. They make the trachea stay open all the time. And if there's a damage to trachea and for some reason those cartilages collapse, then the patient won't be able to breathe anymore. Esophagus, on the other hand, could be open or closed, right? Depending on what? I shouldn't move, right? Did you say peristalsis? Yes. So depending on the movement of the GI tract or the esophagus, esophagus could be open or closed. Let's go this way. In this picture, it happened to be closed. But we know it's behind the trachea, and it is right there. Here's another CT image where you can see the esophagus that's shown right here, and then the trachea right anterior to it. Do I have another one? Even one more. So this one, esophagus happened to be open, right? So we caught it where it was open. So this is the esophagus and this is the trachea. Okay? Cool. Let's talk about the heart and the vasculatures around it. Do you like my cat pictures? Oh, I know, they're cute. I thought this looks like a heart, right? These are not cat people. Okay, so the heart. What does heart do? So it's a muscle, right? Heart is the muscle in the middle of the thoracic cavity. It pumps blood into the rest of the body. Usually the heart, and it's funny because the base of the heart happened to be on top, and the apex of the heart happened to be at the bottom. That's just the way the anatomy of the heart is. And actually, the apex of the heart turns a little bit to the left. That's why we think the heart is on the left side. It's actually in the middle of the chest, turned a little bit to the left. Heart has chambers and valves, correct? What are the chambers of the heart? Right and left atrium, right and left ventricles, right? So we'll look at. So what's important, some of the structures that's important about the heart, and we all need to know, is the pericardium. There's a sac around the heart. It looks like every structure has something around it to protect it, right? So heart also has a sac around it that's called pericardium or pericardial sac. It also has fluid inside of it, in between that sac and the heart, again, to make sure the heart is being cushioned. So that's pericardial sac. However, the muscles of the heart also, the wall of the heart also divides into several layers that we'll talk about in a second. So I'm showing you just some CT and MR images that show the heart, but I want to get into here where you can actually see the layers of the heart. On the layers of the heart, you have epicardium, right? So epicardium is the outermost layer of the heart. You have myocardium. Myo means muscle, right? So the muscle of the heart, middle portion of the heart. And then you have endocardium, which is the innermost layer of the heart, which is actually covering all the valves and inside the heart. So these are the three layers of the heart you need to know. Very important. Epicardium, myocardium, and endocardium. 3 layers. Here's another view of the heart where we're looking at actually the ascending aorta coming from the left ventricle, going up and making it into the aortic arch. And then from here you actually have descending aorta going down all the way to the rest of the body. And we'll go over that in just a second, but I want you to get a picture of how the heart and the great vessels work. You have the superior vena cava. You also have inferior vena cava, which is not shown here at the bottom. And these are all the blood throughout the body. So this is another CT that shows the heart and the ventricles and the. This is an MRI of the heart. So think about it. MRI, we actually said the person has to be very still when they go in MR. How do they do an image of MRI of the heart if the heart's always pumping? They would see a blurry picture if it was just a regular MRI, right? Any ideas? We'll talk about it at the end. There's actually a way to make sure when you're, because you know your heart is not always moving, right? Systolic and diastolic, right? Systolic is when it contracts and diastolic is when it relaxes. Right when it relaxes and it's not moving, that's when we're going to synchronize our MRI sequences to the movement of the heart. And that's how we can get the heart images like this and not blurry. So there's a way. You can actually, when you do a heart chest MRI of the image of your patients, you actually connect them to EKG. And that way you can synchronize their heart movement with your sequences.
So is it like the CT of like a CT heart?
Sometimes.
So you like do the ROI and you have to feed it and everything?
Yes, like that. Although MRI is a lot more sensitive to movement than CT is. So they have to be really careful with that. But that's how they do it. So let's look. This one, this is my favorite image. This is the one that shows all the circulation from everywhere, from the blood and in the blood. From the heart and in, and also from the body to the heart. So let's look at the ventricles first. So you've got the right ventricle here. Let's not move. You have the right ventricle here. You have the right atrium here, correct? There is a valve in between them. What do we call it? A tricuspid valve. Important. You need to know all the valves that are between the chambers of the heart. That's very important.
Do we need to know both names? Like tricuspid and right atrium?
You don't need to. You need to put both names, but you need to know both names because you can call it either. Right, you can call it either the tricuspid valve or atrioventricular valve. Okay, so on the other side, the left ventricle, right, the left ventricle is here. Let's make it blue. And then you have the left atrium, and there's also a valve in between them. What's that valve called? Bicuspid or mitral valve. So why is the left ventricle bigger than the right ventricle? That's the side that pumps the blood to the aorta and then gets the blood to the rest of the body. So obviously the left side of the heart is bigger because it contracts a lot harder. It contracts and sends the blood. So we have oxygenated blood that goes from the left ventricle to the tricuspid valve, to ascending aorta, to the aortic arch, and then all the way down to the descending aorta, to the rest of your body. So that's how oxygenated blood works. On the other side of the heart, the right side of the heart, you have the deoxygenated blood that's coming from the rest of the body, and they're coming by inferior vena cava and superior vena cava. They're going into the right atrium. From the right atrium, it passes the valve, which is called tricuspid valve. It goes inside the right ventricle, and from the right ventricle goes into, what are these? What arteries are those? Pulmonary arteries. And then pulmonary arteries take the deoxygenated blood where? To the lungs to get oxygenated and then bring it back to the heart again. This is where arteries and veins are really important to know. So arteries are the ones that, the difference between, in the heart especially, this is how you want to distinguish between the arteries and veins. Arteries are always taking the blood out, away from the heart. Arteries from the heart, they take blood away from the heart. And veins always bring the blood inside the heart. That's how you can distinguish between in the circulation of the blood in the heart. And that's really important. Some of the arteries may or may not have oxygenated blood, right? For example, pulmonary arteries, do they have oxygenated blood? No. Deoxygenated blood. They take it to the lungs. How about pulmonary veins? They actually have oxygenated blood. They bring it to the heart. So if you look at it as distinguish it that way, arteries always take the blood away from the heart. Veins always bring the blood to the heart. And then you'll never make that mistake. Okay? Questions about the circulation? I actually have arrows to help you. For the blood flow through the heart is actually what I just said. I made it into these arrows for you. So superior vena cava, inferior vena cava. This is the deoxygenated blood, goes into the right atrium. Excuse me. From the right atrium, it goes through the tricuspid valve. It goes through the right ventricle. It goes through the pulmonary semilunar valve and then pulmonary arteries and then to the lungs. On the other hand, oxygenated blood comes from the right and left pulmonary veins. It goes to the left atrium, through the bicuspid valve, goes to the left ventricle, goes through the aortic semilunar valve, goes to the ascending aorta, aortic arch, and then descending aorta, and then the rest of the body. So you need to know the circulation of the blood both ways. Very important. Questions? Yes.
So we don't need to know the valves as the blood is entering the heart, so from either the vena cava or the...
No, I didn't mention those valves from the vena cava
So we
too.
don't need to...
I didn't know. I didn't mention those, no. My main, what I put here, the valves that I put here are important for you to know. So let's go back to this picture again. Now, besides the blood circulation, what else do you see in this picture that's really important? Layers. Layers of what? The heart? Yeah, layers of the heart. What else? What else about the aortic arch? What's coming out of aortic arch? The three arteries. Those are the great vessels. Those are very, very important. And I know probably Ed is going through something like this at this time. Is Ed, no, not covering it? He will. He'll cover. Because him and I at some point overlap a little bit on the greater vessels. So the three main vessels that are coming out of the aortic arch: brachiocephalic trunk, there's the left common carotid artery, and then left subclavian artery. And these are the 3 vessels. So let's look at those. So now great vessels, I also put them like this because you need to know, okay, it's coming out of the aortic arch, but what's happening to it afterwards, right? So these arteries that are coming out of the aortic arch, they also branch off and go everywhere. We'll look at them later on when we look at the neck, CT and MRI of the neck. You'll see carotid arteries going up and feeding the head, some of them feeding the face and all of that. But for now, I want you to know this and the branches that coming out of the aortic arch. So the main branch, the brachiocephalic artery, turns into right common carotid and the right subclavian. The right common carotid turns into the internal and external carotid. And then the right subclavian turns into the right vertebral. Again, these are all arteries that will go up in the head and feed the part of the back of the head, front of the head, face, all of that. Later on you'll see. The next branch of the aortic arch is the left common carotid artery, which goes up again into the neck and turns into the internal and external carotid artery. Third one from aortic arch is left subclavian, which turns into the left vertebral artery. For now, this is all I want you to know. I won't ask you what happens to the left vertebral or internal, external carotid. For now, this is all you need to know. Okay, let's look at them again. So now we're looking at the heart and the aortic arch posteriorly. Isn't that fun, looking at your heart from the back? So again, you're looking at the 3 branches, the brachiocephalic, common carotid, and the left subclavian. Common carotid is almost always in the middle, although there are some patients that have variations of these branches. You may have a patient who has 4 branches coming out of their aortic arch. Don't be surprised. But normally, for a normal patient, this is how it would look like. I want to, let's see. I want to add a slide. How do I add a slide?
The plus sign is bottom one.
The bottom, this one. Oh, no, it doesn't. All right. So I want you to look at actually take a piece of paper out. I want you to draw with me because this is really important. We're going to draw the aortic arch. And we're going to find out what it looks like on a cross section when we look at it on a CT or MR. Okay? So when I draw, I want you guys to draw as well. Mine's going to be red. Ready? Here's my aortic arch. And I'm not even going to show the heart. I'm just going to start from the ascending aorta, aortic arch, and descending aorta. Very simple, right? So, let's say I have a slice that's going through here. What would that structure, what would the top of the aortic arch look like on a CT? You're looking at it from the top. What do you think it would look like? It'll look like a circle or like an oval shape like this, right? How about here? If my slice is right there, maybe just a little bit bigger, right? Maybe just a little bit bigger. How about here? What would my slice look like on a CT? So it would look like something like this, right? It'll have 2. One that is a little bit smaller from the ascending aorta, and the other one would be from the descending. What about after this? What would my slices look like?
You just have descending.
You would have just the descending, so what would it look like? Just one hole. On the left side or the right side? Left side, because remember the aorta goes to the left side of the body. You always see the aorta, you always see this hole, this circle on the left side. The one that's on the left is aorta, the one on the right is... There's another hole on the right side. What's that one? IVC, correct. Inferior vena cava. Okay, good. I wanted you guys to kind of practice and get a feeling. So now, okay. Okay. All right, before we go into the next, I wanted to show. So now I'm looking at, I wanted you to look at the other slide though. Okay, so now looking at this CT, where am I? Am I at the aortic arch, lower, or where? Where am I?
You're sliced between the heart and the top.
Am I inferior to the arch or superior to the arch? Inferior to the arch. I've passed the arch already. You don't even have to look at this because this is actually not a good representative of this slide. So don't even look at that. You're looking at the ascending and descending aorta. There's no vision. You can't see the aortic arch. You're way past it, right? So that's where the two holes are. Here, same thing on this CT. Ascending aorta and descending aorta. Remember the hole, the circle that you said you'll see? It's on the left side. But you're still looking at the ascending and descending. Remember, you're not all the way out of the ascending aorta yet. Here, the same thing. This is an MRI of the chest. You're looking at the, you're actually looking at the descending aorta at this point now. You're way down there. You're looking at the ascending and descending still, right? So once you're out of this area, when you go down, you don't see ascending anymore. It's all descending or abdominal aorta all the way down. Okay? Questions? It's pretty clear. Yeah, good. Here are the branches of the aortic arch again, just to show you where they're going and just a little bit more detail of what we were talking about. Brachiocephalic trunk turns into the right common carotid and then the right subclavian. Here's your left common carotid artery that goes up and turns into internal and external. And here is your left subclavian artery that goes and turns into vertebral. Same thing, it's a 3D actually of a CT of the aortic arch. Again, another one, this is actually a CTA they were doing and they did some reconstruction. Again, looking at this, now you're actually above the arch, you're looking at some of the subclavian, you're looking at the brachiocephalic, and all of those branches coming out. Now, on a CT like this, I wouldn't ask you about the smaller arteries and the branches like this. I'm more into the main branches that come out of the aorta. Okay, so before you run out, just hold on a couple more minutes. Is anybody watching Walking Dead?
It's not back on yet.
It's not on yet? What's it doing back?
I think in November.
Okay, so let's go over some of the smaller veins out there that act with the circulation. Now we talked a little bit about inferior vena cava and superior vena cava, and we said those are the two main vessels that take the deoxygenated blood from everywhere, all the body parts, and they bring it towards the heart. Now, there's a system that actually helps all that circulation of the blood to be kind of connected. The inferior vena cava, IVC, and SVC, they have to be connected. And that connection happens with the azygous system. We call them azygous system. Azygous vein is part of this system, and hemiazygous vein is also part of this system. See how they're kind of collaborating and getting all the blood from everywhere, and they're connecting the two inferior and superior vena cava together so that they can get all the blood from everywhere to them. That's what they do. So where are they CT, and how can we recognize them? They're very small. I wouldn't be surprised if you guys can't see them on a CT regularly, but if you look for them, you should be able to see them. So here's the azygous vein, this black part right here, right there. I'm going to circle it. That's the azygous vein. And here's the hemiazygous vein that is on this side right here. So you can tell just by looking at it. So hemiazygous vein is always going to be on the left side. where the descending aorta is, and then the azygos vein is going to be on the right side for the most part. Let's go to the next. So here's another one, is a CT that shows azygos and hemiazygos again. So hemiazygos on the left side and azygos vein on the right side. Again, next time you do CT out there, look for them and see if you can recognize them. Very, very hard to distinguish, but they're still there, and you should know what they do. Questions? Want to take a 5-minute, guys, before we get into the thoracic muscles, or you want to continue? Just continue. Let's go. Let's get it done. Okay. So I also have a YouTube for thoracic muscles. If you want a little bit more information, they have a really good YouTube short video that you can look at. It's just the basic anatomy they're looking at, but it's more what I want to talk about. So there are certain important thoracic muscles that I want you to know, and I think I listed them on your outline. You have pectoralis major, that's important. Pectoralis major muscle, that's this one right here. You have trapezius muscle. Trapezius muscle is this one, and you can see it from the back as well. We'll look at the posterior portion as well. Latissimus dorsi, that's the one that covers the back and comes laterally towards the front. When we look at abdominal muscles later, we'll look at latissimus dorsi too, so it kind of overlaps here. Pectoralis minor muscle, that's important. So pectoralis major, those are your pec muscles, right? Superficial. Pectoralis minor is more deeper than that. So if you take one layer of the pectoralis major, underneath it will be pectoralis minor. And I think that's all I had you on the thoracic muscles. Not too many of them that you need to know. Posteriorly, you'll look at them again. For example, you have trapezius again, right here. Obviously, you can't see the pectoralis muscles, but you can see the latissimus dorsi here. So it comes from the back all the way from the side. The rest, the ones that you're looking on the right side, we'll go over when we do shoulder MRI. You'll look at all of those, teres minor, major, all of those later on. But for now, for chest, those are the few muscles you need to know. So he's taking his dinosaur to school, and he's going to give him a list of all the kids he needs to eat. Who are you taking to school? Let's talk about some of the abnormalities of the chest, and why do we do CT, which is circling us back to why, right? Why do we do all of these, looking at all these chest images and CTs and MRs? What are some of the diagnoses you see out there with patients that come for chest CTs? Alexander.
Follow up to an aneurysm.
Okay, follow up to an aneurysm. What else?
Rib fracture.
Rib fracture, okay. What else do we have out there?
Dissections.
Dissections, that's right. If they suspect of any kind of dissection or aneurysm, obviously they want to do a CT. How about traumas, right? We get the traumas all the time where they want to do a chest CT right away. If there's any kind of stabbing, any kind of chest wound, they will do a CT chest. So here's an aortic dissection, and I want to explain what aneurysm is first, and then we'll get into dissection. So what do you think an aortic aneurysm is? And how big should aorta be? How big should the diameter of aorta be? 2 centimeters. And when it's bigger than 2 centimeters, when it's bigger than 3, then we call it an aneurysm. When the aorta is dilated, when a big artery like the aorta is dilated, that's called an aneurysm. Then what happens in an aneurysm? What happens to the blood flow when there's an aneurysm? Slows down, right? The blood flow slows down. The vessel cannot transfer as much blood as the body needs, and therefore your heart doesn't get enough blood. The rest of the body doesn't get enough blood. So if an aneurysm continues let's say this aneurysm continues for months and months and we don't notice it, what happens is an aortic dissection, which means there's actually an extra wall inside the lumen of the vessel that's not supposed to be there. So a wall is being produced. So now you have a true and a false lumen. And there's some blood that's going through both those lumens, both those holes. And is that good? Absolutely not. It reduces the blood flow. You don't get as much blood flow as your body needs. And then patient can have heart attack, they could have a stroke, they could have but it starts with the pain. Usually they say pain in the chest, pain in the stomach, it starts like that, and then when they come to the hospital, something like this, they may not even live. A famous actor, John Ritter, died of this within hours. They had no idea what had happened. He always had high blood pressure and he was a little bit overweight in his older years, but he went to the hospital 4 hours later, he died. And it was aortic dissection. So if they don't catch it in time and if there's bleeding going on, they can't take him to surgery fast enough, the patient will die. Yeah?
Can you explain the whole false lumen thing? How does that work?
Sure. Let me actually, I'm going to draw it for you. So here's a normal aorta, right? Normal aorta that comes like this. Now if the aorta becomes bigger at some point, let's say there's an aneurysm in the aorta, this makes the wall weaker. As the wall gets weaker and weaker, there's not enough blood going through as it's supposed to be, up or down, doesn't matter. And then when this wall gets weaker, sometimes the parts of this wall gets separated and it becomes like this. Okay, so the walls of the actual vessel chips off, right? So now instead of looking at aorta in a circle like this, you're looking at an aorta something like that, because there's an extra wall right here. And then what was the true lumen, which was here, now there's a false lumen, which is this one. So now there are two pathways of the blood, right? One of them is the actual pathway, the other one is the false pathway, the one that was created because of this little wall here. And that's why, and if you look actually, even in a CT in here, the true lumen has a brighter, there's more blood flow in there, and the false lumen is darker, is grayer.
Right, because you would have to have sort of an exit site, so you would have the 2 points at which the lumen has attached to the wall lining.
Exit site, what do you mean?
Sort of, well, if it's open from one side, you would then just have a pocket basically where blood can stay and just.
Right, so it could be like a pocket, so it could be a smaller area, right, absolutely, it could be a smaller area, or it could be the next image where I'll show you, where the entire aorta is like this. The entire aorta, if you look at it, is like that. So it has the 2 lumens. Sometimes it stops somewhere, sometimes it goes all the way. And this is obviously more dangerous. When it contains the entire aorta, it's a lot more dangerous than when it is just a smaller area. This can be repaired probably, whereas the other one is just devastating. Okay, so that was a good question. And to make it, so we said, can I draw on this? I can draw, right? So we said the normal aorta is like this, and when there's an aneurysm, it gets bigger, and the wall of the aorta, which is normally like this, it becomes bigger, and this wall chips off. Some of it chips off and goes inside the lumen, and now the aorta looks like that, and there is an extra wall inside of it. The next one, this is where you can actually see the aorta, and this is a CTA. You can see this is not a normal aorta. Look, on this side you have a bright red. On this one, not so bright. This is the false lumen. And look how it involves the entire aorta. There's a dissection throughout the whole entire aorta. And this is extremely dangerous. So usually they take him to surgery right away and fix it. but it's not always possible. Some of the other pathologies that we see for the chest, and we end up doing a chest CT after a chest x-ray like this, is when patients inhale particles. It could be people that do mining. That we don't see those patients a lot here, but there's still some that are out there in the mining areas, for example. So silicose mining can do this to your chest when you inhale particles. Asbestosis also. So this one is with asbestos, which you inhale asbestos particles and it goes into your lungs. It deposits into your lungs and they don't go anywhere. And you can actually see it on a CT where you're looking at calcifications. See all these calcifications here? That's because of asbestosis. So sometimes we do CT chests because of these kind of pulmonary pathologies. The other one that I mentioned, metastases, pulmonary metastases. So it's not primary lung cancer, but it's the cancer that comes from something else. A lot of times breast cancer can give you lung metastases because of the proximity of the structures. So that's why patients with breast cancer are often being chest x-rays. They want to make chest x-rayed because they want to make sure there's no metastases from the breast to the lungs. But this is how a really severe end-stage pulmonary metastasis would look like. Have you guys heard of COPD? It's a pathology of the respiratory system. So it's chronic obstructive pulmonary disease, COPD. And it has several different kinds of disease that can cause that. One of them is emphysema. So I always talk about emphysema because it's really important. It's out there. We see a lot of patients with emphysema. We do a lot of chest x-ray on them. How do you tell a patient has emphysema, even without knowing anything about their history? Barrel-chested. What else? Struggling to breathe. They usually actually come in with their oxygen tank because regular breathing is not doing that exchange of oxygen for them in their lungs. So usually people with emphysema, their lung tissue is not there. There's a lot of holes in their lungs, so that gas exchange does not happen properly.
Like the broken alveoli, like instead of being lots of small ones, it's just big clusters?
It's big, exactly. Big clusters. Sometimes they're actually there's no alveoli. They have gone. There's necrosis tissue in the lungs. So if there are no lung tissue, there's no alveoli. They can't breathe well. If they come into you, they're breathing like this. Because that's the way they've trained themselves to get the oxygen. And you're right, barrel-chested usually. And so what do you do with people with emphysema? Do you increase your technique or decrease? Why decrease? There's no tissue. When the lung tissue is gone, you don't have to use that much technique. Use less technique because it's going to go right through them with the emphysema. Okay. Now what about something like this? If you knew they had pulmonary metastasis, do you increase technique or decrease? This looks like you should increase because there's so many patches around their in their lung. But you wouldn't know if you didn't. All right, last topic of the day, which we already kind of covered, is the cardiovascular MRI. Well, we kind of already looked at some of the MRIs, and we know that the MRIs of the heart have to be oblique, right? Because the heart is situated in an oblique plane. So these are the planes of the heart: sagittal, coronal, axial, and oblique. What we just mentioned about how to do MRI of the chest is basically cardiac or physiologic gating. That's what the term is, to make sure that the heart is moving at the same time we're doing our sequences, or vice versa. We're doing the sequences when the heart is not moving. This is a technique to reduce the motion artifacts that come from the heart, and basically uses EKG to synchronize your heart rhythm with the sequences of the MRI machine. And like you said, they use it in CT as well. Okay, so that's called physiologic or cardiac gating. This is just the coronal image of the heart. There's lots of images like this in your book as well. I don't want to go through all of it, but you can tell the ventricles, some of the atrium are showing. That's it, and we're done. Thank you guys.